The following podcast is part of a certified educational activity titled Addressing Unmet Needs in the Treatment of Patients with Choroideremia, Exploring the Use of Novel Therapies to Restore Vision with Dr. Byron L. Lamb. Access the entire activity and complete the post-test at peerview.com/AGK860. Downloadable slides and practice aids are also available.
I'd like to talk to you about an interesting disease today called choroideremia. It is an inherited retinal degeneration. The reason we're talking about it because there's a potential that we will have a new treatment for this in the near future. Choroideremia is an inherited retinal degeneration, and our thoughts about inherited retinal degenerations, or IRDs, have really changed. And the reason for this change occurred in 2017, when the first ocular gene therapy was approved for RPE65, which is inherited retinal degeneration that affects mostly children. Choroideremia is an X-linked recessive inherited retinal degeneration, which means it affects primarily males. The prevalence is 1 in 50,000, which also means that 7,000 people approximately in the US have choroideremia. The symptoms of choroideremia consist of gradual loss of peripheral vision and night vision, and this starts fairly early in childhood, and it gradually progresses. So this condition basically is slow, is insidious, and it gradually catches up with an individual until the affected person is in their young adulthood, and they realize, well, my vision isn't quite right. And by the time they're middle age, the vision gradually constricts further and further, and the patients start to have decrease in central vision. So this is a continuous progressive condition that it can be visually devastating. Now, what causes choroideremia? Choroideremia is due to gene changes. And the particular gene that is changed in choroideremia is the REP1 gene. And this gene is located on the X chromosome. Most REP1 mutations are null mutations. And what this really means is that the mutation in the gene causes a truncation or a shortening of the protein, so it can't really function. REP contains two forms. One is REP1 and one is REP2. REP1 is the one that is absent in choroideremia. REP2 activity can compensate for this deficiency in most tissues throughout our entire body. On the other hand, when REP1 is absent, the key cells in the retina that converts light signals into nerve signals are not really working properly. So REP1 absence affects the retinal pigment epithelium, the choroid, and also the photoreceptors. Choroideremia signs and symptoms sometimes are similar to retinitis pigmentosa, and often patients come to me because they are misdiagnosed as retinitis pigmentosa. Both choroideremia and retinitis pigmentosa have gradual decrease in peripheral vision, night vision. This starts sometimes in childhood in retinitis pigmentosa. It virtually almost always starts in childhood in choroideremia. Now, what are the other distinguishing features? Well, I think when you look at the retina, what one sees is that both have pigmentary changes. If you do visual fields, the visual fields are constricting both. But clinically, there are some key features when you examine the retina that can help you to distinguish retinitis pigmentosa from choroideremia. First of all, in choroideremia, the blood vessels are relatively preserved. You can trace the blood vessels from the optic nerve all the way out into the peripheral retina. On the other hand, in retinitis pigmentosa, the blood vessels, they're thin, they're attenuated. And as you trace them out, they sort of disappear into areas of pigmentary retinal degeneration. Another feature that distinguishes retinitis pigmentosa from choroideremia is that in retinitis pigmentosa, you often see these pigmentary clumps that are in the mid-periphery or the far peripheral retina. Whereas in choroideremia, there are patches where the choroid in the retina are missing, and you don't see this pigmentary clumping. Another feature that helps to distinguish the two entities is, in fact, the optic nerve. The optic nerve in choroideremia often looks normal or possibly mildly pale. On the other hand, in retinitis pigmentosa, the optic nerve can gradually become pale, and it becomes sometimes markedly pale over time. The other features that you can look for to diagnose choroideremia in the clinic includes autofluorescence. In autofluorescence, in choroideremia, you'll often see that the small area of functioning retina in the fovea has a hyperfluorescence to it when you do the autofluorescence. And this represents the area of the functioning retinal pigment epithelium that is dysfunctional, but they're hyperfluorescent. The OCT is a very important tool to distinguish retinitis pigmentosa from choroideremia. On the OCT, the preserved retinal pigment epithelium is seen as a very thin, bright line. And underneath, you do see some intact choroid. Far out into the periphery or outside the fovea, you can see an absence of the choroid in the retinal pigment epithelium, as well as, of course, no photoreceptor layer. There are no specific studies that have looked at the effect of choroideremia visual loss on the quality of life. On the other hand, there are a lot of studies that have looked at retinitis pigmentosa and other inherited retinal diseases that affects the quality of life. Choroideremia being an early onset retinal degeneration, gradually progressive, it means that a person gradually loses the ability to be independent, can drive, can have good mobility. And of course, this also means that an individual has a psychological burden of this cloud over their head that eventually they will lose the vision. And of course, that also causes anxiety and depression. So I think if we can figure out a way of treating patients with choroideremia and stabilize their vision and maybe improve their central vision to a certain degree, I think that will have potential impact on our treatment of patients with choroideremia. So choroideremia, in essence, there's really an unmet need. Up to now, it's a not treatable disease because there are no treatment, and it's progressive, and it has significant visual impact over time. However, there's hope in the gene therapy. Current management for choroideremia consists of giving the patient low vision aids and also recommending sunglasses to block out ultraviolet light, and also to have the patient have regular visits. And the reason for that is really to pick up cataracts, cystoid macular edema, and the rare occurrence of choroidal neovascularization, which can be treated. There are several factors that make choroideremia a prime target for gene therapy. Well, first of all, this condition is slowly progressive, which means that there is a long period of time of opportunity for the patient to receive the gene therapy. Also, the eye is easy to access surgically to allow for direct delivery of the target tissue, which would be the retinal pigment epithelium and also the photoreceptors. There is also a range of imaging technique, autofluorescence, OCT, intraoperative OCT during surgery that allows for the evaluation and monitoring of this treatment. The AAV virus, the adeno-associated virus, is the one that has been used for gene therapy. And it certainly is very appropriate to use this particular construct to deliver the gene therapy. And this follows in the footsteps of the first approved gene therapy for RPE65 in 2017. So the AAV virus doesn't really cause human disease, so it's quite safe for gene therapy. And what's gene therapy? You take this simple virus, you keep both ends of the DNA of this virus, you pretty much remove everything in between, and then you put in the DNA sequence that can transcribe the normal protein that you want to deliver. And in this particular case, that is Rep1 for choroideremia. And the goal of the gene therapy in choroideremia is really to improve or maintain the function of the remaining retinal pigment epithelium and the photoreceptors. And in this way, you can either maintain the vision or, in fact, improve the vision in some cases. Like most gene therapy for the retina, the choroideremia gene therapy involves subretinal injection. This means that the fluid that contains the viral vector for the gene therapy is injected under the retina where the retinal pigment epithelium and the photoreceptors are. And by doing this surgery, then you can safely place the viral vector where the target cells are. How do we determine a patient is eligible for gene therapy in choroideremia? The first thing, of course, you have to have an accurate diagnosis. And the gold standard for diagnosis will be clinical findings and genetic confirmation of choroideremia. Visual acuity has to be better than 20/200, and also the retinal anatomy has to be deemed reasonable for surgery in terms of safety, and also in terms of the possibility of stabilizing vision and possibly improve vision. There have been several choroideremia gene therapy clinical trials that have been performed. It all started with Oxford many years ago, where a phase 1/2 clinical trial was performed. And patients now have been followed for more than 4 years, and some of the patients have improved vision, and this improving vision have been sustained. There have also been several phase 2 clinical trials in choroideremia to test the gene therapy. This will include studies that were conducted in Canada, in Miami, and also in Germany. There are also other studies that have been conducted in Pennsylvania and Massachusetts. But I think the most important 2 studies that are ongoing are the phase 2 clinical trial that tests the safety of bilateral sequential treatment of choroideremia gene therapy. This is what is called the GEMINI clinical trial. And this is important because this study injects both eyes with gene therapy. The other clinical trial, which is very important in terms of assessment whether this treatment will be approved, is the phase 3 STAR clinical trial. In this particular trial, patients are randomized into control group, low dose group, and also high dose group. For surgery, for gene therapy delivery in choroideremia, a subretinal blast have been raised. And this is very important to use the intraoperative OCT. The intraoperative OCT allows real-time visualization of the different layers of retina as the surgery is being performed. As the fluid is being injected under the retina, the OCT allows the assessment of whether the treatment actually goes through the proper layer, and it also determines whether the retina is not overstretched and there are no retinal holes. When we take phase 1 and phase 2 clinical trials, and we take all the patients together and determine whether there could be any efficacy of choroideremia gene therapy, what we found is that there are approximately 20% of the patients who are called hyper-responders. There are patients who have improved by 15 letters or more. And this is actually quite remarkable because if you compare to patients without treatment in a natural history study called NICE study, where over 100 patients have been followed without treatment, the number of patients that improve by 3 lines is only 1 0.3%. So this is a significant improvement of vision by using the gene therapy. You can also look at the results from phase 1 and phase 2 in a different way. You can see how many of the patients, in fact, have the risk of losing vision. And for patients that have been treated with gene therapy for phase 1 and phase 2, approximately 6% of the patient lost 1 line or greater vision, or 5 letters or greater, versus 13% of patients who were not treated. And these are the patients, again, in the natural history study. And for them, the risk of losing vision is just much higher. When patients are treated in those hyperresponders, when they do respond, in approximately 20% of the patients, and this will be a 3-line of improvement on the visual acuity chart, when would they really improve? Well, what we have found with these hyperresponders is that the visual acuity improvement occurs fairly rapidly. You can often see it by month 1. And certainly this is established by month 3. And there is data now that shows that the vast majority of these patients maintain improvement beyond the 12-month period. The GEMINI bilateral treatment phase 2 study is a very important study because it, again, tried to establish the safety of bilateral sequential treatment of choroideremia gene therapy. And this study is designed in such a way that patients are treated in one eye, and then after a period of months and maybe over 1 year, the patients are treated in the other eye. So patients are treated at different intervals between the 2 eyes. And the aim of the follow-up is to determine that bilateral treatment is in fact safe. Ultimately, if the treatment is approved, the targeted population would be patients who would want bilateral treatment if both eyes are appropriate for gene therapy. And the criteria for the GEMINI study include patients' vision that's as bad as 2200, and the main primary outcome, of course, will be safety, and there are also other outcomes to detect possible efficacy. The STAR phase 3 clinical trial is the study that really aims to determine the efficacy of choroideremia gene therapy. Patients going into this clinical trial, their visual acuity is better than 2200, but the visual acuity is also worse than 2040 or so, in that range. And patients then are randomized. They're randomized either into the control group, where they do not receive any treatment, or they are randomized into the low dose group or the high dose group. The primary endpoint for the STAR phase 3 clinical trial is the best corrected visual acuity. There's also a host of other secondary endpoints which will allow to determine efficacy as well as safety. The results of the STAR phase 3 clinical trial, of course, will be very pivotal in terms of determination of its potential approval by the FDA. There are several emergent therapies in choroideremia. One will be the nonsense bypass therapy, and this is for patients with choroideremia who have nonsense mutations, which the vast majority of choroideremia patients have. And there are some potential drugs that could be potential treatments. There are also retinal prosthetic systems, like retinal implants, that can salvage rudimentary vision in patients who have advanced retinal degeneration. And of course, there's a great deal of research in terms of stem cell treatment that have been found to have safety in early phase studies. Now we'll hear from a patient about his experience with gene therapy in choroideremia. Like other patients, this patient started to have gradual decreased vision in the peripheral retina as a young person, and subsequently as a young adult, the patient was diagnosed with choroideremia. The patient was told nothing could be done, And over the years, he gradually lost more peripheral vision until his central vision began to get affected. He had to plan his life around that. He had to adjust his profession. And of course, he can't drive, and he became very dependent on his family. And I think his journey is a fairly unique one because it really helped us to understand how much of a burden this condition is to a patient, and also how much hope, if potential treatment can occur, can be beneficial to this group of patients.
I cannot express how excited and happy and enthusiastic I am to be able to be taking part in this gene therapy program. It cannot be overstated how important and how amazing and how, well, life-changing this is for me. For most of my adult life, for the last 27 years, I have been facing the reality that at some point I will lose all of my vision. And much of my life has been geared around towards preparing for that, trying to deal with that, making accommodations in my daily life and in my choices of work and living for how I can actually prepare for that. And really, literally, with one magical operation, the entire game has changed. I can actually, look at a future where there's hope, where I may not actually be able to, have to face the world and say, okay, well, at some point, I won't see this all anymore.
Yeah.
I can actually see my children, my beautiful kids, grow up and see my wife as they decide to thanks guys, as they grow up and decide to go on to their own futures. I'll be able to experience all of that in the way that so many other people get to appreciate and take for granted every day.
Oh.
And I am so grateful to to Dr. Lau, to the researchers, to Bascom Palmer, to Dr. McLaren, and everyone who has contributed to the efforts to make this possible. I'm still, I'm about a week past the surgery myself, roughly, but I'm still processing it because, after 27, 28 years of living with the reality of that not being possible, it's still, I'm still taking it in.
The take-home message for choroideremia are the phase 1-2 gene therapy clinical trials show sustained improvement and also maintenance of visual acuity. And this is definitely achievable. It has been published, has been shown, and the results are encouraging. And the safety profile is rather favorable. There are multi-center bilateral sequential phase 2 clinical trials that are ongoing, as well as the randomized phase 3 clinical trial. So what all this means to the clinician is that this is the time to really make an accurate diagnosis of choroideremia and to identify patient with choroideremia and to be able to differentiate them from retinitis pigmentosa patients and then to proceed with genetic testing. This is important because there's a potential for the gene therapy that can maintain vision and also to improve vision. And the time is really to act now, is to proceed and identify these patients, keep them in mind as the gene therapy clinical trial progresses. Thank you.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/AGK860. This activity is supported by an educational grant from Biogen.